Okay.
Okay. All right. Our topic for today is stroke or cerebrovascular accident. And I'm sure that in your course of clinicals that you have had the opportunity to hear them sometimes call for stroke alert. And so this is something that is very common, and therefore it's a high yield in the Nclex, and that is why we have this topic for today. Now, a public service advertisement is always going to include the actions that we have to take as far as stroke is concerned, because a CVA or a brain attack or ischemic stroke or hemorrhagic stroke involves a sudden loss of brain function resulting from a disruption of blood supply to a part of the brain. And thus, it is a public service campaign to always tell people to remember the acronym FAST. And FAST stands for face, and asking the person to smile. If one side of the face drooping, then that's most likely a sign of stroke. And arms, for A, ask the person to raise their arms. Is one weaker than the other, then this is also going to be a manifestation of stroke. And speech, for the S, ask the person to speak. Is their speech slurred? If it is slurred, then it's most likely also to support the diagnosis of stroke. And T is for the time. We encourage people to call 911 right away at the first sign of a stroke. So, with that in mind, let's take a look at the algorithm that we always follow whenever we are going to have a patient with stroke. Well, there's a lot of information over here, but what I wanted to emphasize is that time is of the essence whenever we are dealing with patients with stroke. And that is why there is going to be time elements that we have to observe whenever a patient presents to the emergency room, because we have to have the monitor. Okay, hold on one moment.
Yeah, because I'm hearing both.
That's what it was. It was echoing.
Yes.
All right, is that better? So anyway, the thing that I was saying is that whenever we have a patient that comes into the emergency room, the clock starts there, and we have up to 3 hours to make the intervention. That means to say, beginning either the TPA or having the patient aggressively being treated for the stroke. Okay, so we're not going to go to each one of them because I will be discussing them as they come about. All right, so there are two kinds of stroke, basically. One is what's called ischemic stroke, and the other one is hemorrhagic stroke. Both of them result in depletion of oxygen-rich blood that goes into the areas of the brain. So what is an ischemic stroke, and how is it different from a hemorrhagic stroke? Well, ischemic stroke is caused by a thrombus, meaning to say that there is going to be an obstruction in one of the blood vessels that blocks the blood supply to a cerebral artery. And this is the most common type of stroke. 75% of all stroke are ischemic in nature. And there's also what is known as a cryptogenic stroke, wherein we do not actually know what causes them. But anyway, in some instances, this is going to be something that we really don't understand, and therefore it's called cryptogenic. But remember that ischemic stroke is more common. 75% of cases of stroke is always going to be ischemic stroke. And the causes are many, and it could be as a result of arteritis, a patent foramen ovale, and left ventricular dysfunction, or even septic shock. And usually this condition is preceded by a transient loss of consciousness called transient ischemic attack. Now, the other kind of stroke is what's known as hemorrhagic stroke. And hemorrhagic stroke occurs when areas of the cerebral artery become weak or thin due to long periods of hypertension. And thus, this weakened area or thinning of the blood vessel will result in an aneurysm. And when they rupture, then that would be the cause of the bleeding that is going to be trapped within the cranium. This usually are going to be common in thin arterial vessels. As they are smaller, they're going to be prone for more rupture. So those are the two kinds of stroke. So I had mentioned TIA, which is transient ischemic attack. This occurs when there's a temporary occlusion or blockage of blood flow to a portion of the brain. And the word temporary is very, very important. So this transient occlusion of an artery causes symptoms that sounds like and smells like a stroke, such as slurred speech, visual disturbances, or weakness in an extremity. However, these are temporary and they last 1 minute to as much as 30 minutes. And of course, they disappear without any long-term effect. Now, there's also an interesting term over here, amaurosis fugax, is when there's an occlusion or stenosis of the internal carotid artery, which is going to lead to hyperperfusion of the arterial circulation in the eyes. So this might be presenting then with visual disturbances. So your eyes aren't getting perfused, so this temporarily shuts off the lights. That's amaurosis fugax, meaning to say that there's a blackout. All right, so the treatment and the diagnosis of TIA is the same as stroke. It would include MRI, a CT scan, for example, or a CT angiography. And the treatment is going to be similar to, but not exactly the same as stroke. So the treatment would be to prevent aggregation of blood. So antiplatelets such as aspirin and clopidogrel usually are given to these patients. And then, of course, if there is going to be a source that is cardiac in origin, for example, if there is going to be a cause like atrial fibrillation, then anticoagulation is going to be in order. And then, of course, carotid endarterectomy is a procedure wherein we would open the carotid arteries to remove the plaques that are blocking the circulation into that area. And we could also put a stent. And a stent is similar to a spring of a notebook. So I'm going to illustrate that. Well, right here. It's like a spring in order to keep the arteries open and prevent them from collapsing. So that's a stent. All right, so what are the risk factors for stroke? Well, there are modifiable and non-modifiable risk factors. The non-modifiable is that whenever you are older than 45 years of age, smoking and atrial fibrillation, these are all non-modifiable risk factors. Female, 55 to 75, and this is going to have a higher incidence in women than it is with men. So as much as 25% more chances of having a stroke if you're a woman. And then it is much more common among Blacks, among Asians, and also among Hispanics. The modifiable risk factors are hypertension. Obviously, we can control it. We cannot cure it, but we can control it. Atrial fibrillation. And the reason why atrial fibrillation is going to be a modifiable risk factor is because in atrial fib, what happens is the heart does not beat properly, and therefore blood clots can form, particularly in the left atrium. Now, this is a common question in the Nclex. I wanted to underscore why is it that atrial fibrillation produces more CVA or stroke than pulmonary embolism. Okay, so if this is the right atrium, and this is the right ventricle, and the lungs is right over here, and left atrium, and left ventricle. If blood clots come from the right side of the heart, like the right atrium or the right ventricle, they're usually filtered by the lungs, so it causes pulmonary embolism. However, in patients with atrial fib, actually the blood clots form on the left side of the heart. Why is that? Because on the left atrium, there is an appendage. There is a appendage, something like this. And so when the atrium is not beating properly, this area over here could cause blood clots to form easily because they are not within the atria itself. And this, therefore, is the source of your embolic stroke. So this is the emboli that would go into the brain. And the reason for that is if this is the heart, the left ventricle is going to have the aorta right over here. And immediately in the aorta is going to branch the carotid arteries. So when the blood clot comes out of the aorta, it's most likely to go up into the carotid arteries. Okay? All right. So the other modifiable risk factors are hyperlipidemia, obesity, smoking, diabetes, and carotid stenosis and valvular heart disease because of the fact that when you have valvular heart disease, there's likelihood of blood clots to happen as well. And periodontal disease. I don't know if you have heard about it, but a lot of people who develop stroke sometimes do not have any of these risk factors, but the only thing that happened was they have an infected tooth, which caused them to have a stroke. And this is a rare one, but it actually happens. Actually, I know of someone that died as a result of a stroke secondary to a tooth infection. And then, of course, substance abuse, particularly cocaine, because cocaine actually is a potent vasoconstrictor and therefore can cause severe hypertension. And then the other one is alcoholism. Now, let me just talk a little bit about this alcohol. When you have alcohol, we always think about the fact that it is going to be something that's bad. But you also have heard that a glass of wine a day is going to be good, and you are correct. Less than 2 drinks per day for men and less than 1 drink for women actually reduces the stroke. But if you increase that alcohol intake, it increases the risk for stroke. So as far as alcohol is concerned, it depends on how much they drink. Remember, 2 for men and 1 for women is going to be protective for stroke. But more than that is going to be a risk factor to the development of stroke. Okay, so let's go to our first poll. All right. So what's the difference between an emboli and a thrombi? Okay. So the correct answer here is letter B, ischemic embolism. So embolism means to say that this is a clot that occurs outside or forms outside of the brain and then comes into the brain and obstructs an artery. So an emboli is a clot coming from other areas. All right, a thrombus would be something like this. Supposing that this was the artery, and you now have a deposition of lipids and cholesterol over here, forming a plaque, okay? And they begin to grow and grow, and sometimes they rupture, and when they rupture, blood is going to clot around this area. This is what's known as thrombosis. All right. An emboli is what happens. The heart is right over here and it produces the blood clot, and that blood clot lodges into one of the arteries of the brain, blocking, therefore, the circulation. That is what's called an embolism. So letter B is the correct response. It leads to ischemia and eventually death of tissue. Okay, so you are correct. The fact that this patient's blood pressure is elevated chronically, then this predisposes him to the development of stroke. The fact also that he's an Asian male is going to be one other risk factor, but because we have hypertension here chronically, therefore this is stronger than the fact that the patient is Asian.
I
Okay.
didn't pick
So
A.
question,
Oh,
yeah, go
Sure.
ahead, Lindsay.
I didn't pick A because it said male, and
Huh?
I remember you saying female.
Yeah,
Correct.
and it also
Correct.
said history, and I wasn't sure. I don't know.
No,
We
you
were
are
on the same page.
you
Okay.
are correct. You are correct. It's more common in women. Do you remember they surpass men by 25%. So and the fact that letter C didn't say whether or not he is a man, all right, or a male. Well, I guess this is a male, but anyway, that's good. Steroids does not have anything to do with the stroke, as well as iron supplements. And of course, those B and D do not have any bearing in it. Okay, very good. I'm glad that you're paying attention. All right, let's go to another one. Your answers?
I was thinking this one's
Me
tricky.
too. I don't know.
All right. So you remember this is hemorrhagic stroke.
Yeah.
Okay, so let's see. Now, if it's hemorrhagic stroke, do you remember I said that hemorrhagic stroke is usually formed by aneurysms. And what is an aneurysm? An aneurysm is an outpouching of the blood vessels like an artery. And so if you have chronic hypertension, for example, your arterial walls are going to be weak, and then they form this thing like this. And this is what is known as an aneurysm. So it's almost like a hernia of the blood vessels. There's an outpouching of it, which is going to be weak. And this is going to be predisposed to rupture. So this is an aneurysm. And this is going to be the number one cause of a hemorrhagic stroke. Other things that could cause a hemorrhagic stroke would be, of course, the accidents or traumatic brain injury. So letter C is the correct response, because this patient had an aneurysm, which means to say that he might have other aneurysms as well as a result of his chronic hypertension. Okay. All right, so now we have distinguished between ischemic stroke and hemorrhagic stroke. Now let's take a look at the pathophysiology. Whenever you have a disruption in blood flow or occlusion, then there will be a cerebral blood flow that's going to be diminished, and therefore oxygen and glucose cannot reach the brain. And therefore, it's going to lead to necrosis or death, apoptosis or cellular death, and then inflammation. And that's exactly what happens with a stroke. Now, one cannot talk about stroke without talking about the blood vessels that feed the brain. And there are several arteries and veins that actually feed the brain. But the brain receives blood from the right and the left carotid arteries. So the right and the left carotid arteries provide the brain with blood, and it also is going to have supply from the left and right vertebral arteries. So these are the carotids, and at the back are going to be your vertebral arteries. So these are the major blood vessels that are going to feed the brain. But there are several other tributaries of these arteries, and I wanted to just look at the major ones. The anterior cerebral artery. The anterior cerebral artery is going to be one that is going to be commonly, commonly blocked, and therefore results in a anterior cerebral artery stroke. And usually when we have symptoms of foot and leg that are going to be paralyzed, this is usually as a result of the anterior cerebral artery stroke. But the more common one that is actually going to be tested quite often in Nclex is the MCA, or the middle cerebral artery. And middle cerebral arteries usually result in aphasia, and that is why it's usually tested in Nclex. So this is an MCA, is the one that is going to cause aphasia. And then for your posterior cerebral artery strokes, these are the ones that are going to give you hemianopsia or hemianopia. And lastly, vertebrobasilar artery strokes are going to be the ones that produces the V's. So it's easy to remember. This one is the easiest to remember because they usually cause vertigo, visual changes, vomiting, vibrating eyes, which is also known as nystagmus. So these are the ones. So whenever you are looking at strokes, this is very common in Nclex. This posterior cerebral artery is very common, and this particular vertebrobasilar artery is also very common. But again, with vertebrobasilar artery stroke, always remember the V's Okay, so vertigo, visual changes, vomiting, and vibrating eyes. In the middle cerebral artery, aphasia, it causes aphasia, and posterior cerebral artery causes hemianopia or hemianopsia. Okay? All right. Whenever there is going to be a test in the Nclex, they always want to test you whether or not you remember your brain anatomy. So there are three main parts of the brain: the cerebrum, which is going to be the one that makes us intelligent, and this is the one that is going to obviously being the ones to control movement and sensation, speech and language, anything that makes us intelligent. And then the middle portion of the brain, right over here, is the cerebellum. And the cerebellum is going to be for coordination of fine movement as well as balance. And lastly, the brainstem right over here is going to be for our biological functions, like the control of blood pressure, pulse rate, temperature, and so on. So those are the three major areas of the brain. But most of the questions actually in Nclex is going to ask about the lobes. So whenever we are looking at the cerebrum is going to be divided into 4 lobes. And they are the frontal lobe, the parietal lobe, the temporal lobe, and the occipital lobe. So each one of them are going to control some functions, and thus it's important for you to remember. So the frontal lobe controls the motor motor control, as well as problem solving and speech production. This is where the Broca's area is located. Okay, so the frontal lobe is where the Broca's area is located. That is the mechanics of speaking. The temporal lobe, on the other hand, is mainly for hearing and language comprehension. So this is what's called the Wernicke's area. And this is often tested. So F frontal for Broca, temporal for Wernicke. So the way that I remember it, this is frontal is going to be closer to letter B, okay? And temporal is going to be closer to W, to Wernicke. So sometimes I get confused, which one is which? Is frontal Broca or is it Wernicke? And you're thinking, so now remember which one is closer to that lobe. Frontal is closer to Broca, okay? And now parietal is going to be for body orientation, the occipital, and this is the most important one because of the fact that sometimes patients will have visual problems, and that would represent the occipital lobe. And lastly, the parietal lobe is going to be for body orientation and, of course, sensory discrimination. So those are basic anatomy that we might have forgotten, but there are questions similar to this. So let's take a look at this poll. All right, so the correct answer is letter D. The temporal lobe, as we know, is going to be responsible for hearing It's also responsible for learning and feeling as well. Okay, let's go to the next one.
There's no pull.
Yeah, I'm looking for the poll. Hold on one moment. Somehow or another, I don't have this on the poll. Here it is. It was on the wrong number. Very good. Letter D is the correct response. In addition to this, the occipital lobe is responsible for color perception and vision. Okay. Let's go to the next one. MRI. Very good. So the cerebellum is important for coordination as well as balance. All right. When we look at the cerebrum, the brain consists actually of two halves. One is the left and the other one is the right. And we call these the hemispheres of the brain. There's important principles that we have to behold, and that is that the left brain is going to any deficiencies in the left brain or disease in the left brain is going to cause symptoms on the right side of our body. And likewise, if we have problems with the right hemisphere of the brain, the manifestations is going to be contralateral or on the left side of the body. Okay, so that's the general principle. Now, whenever we're looking at the left brain and the right brain, the left brain actually therefore controls the movement of the right side of the body. And it's important for critical thinking as well as logic and reasoning and language. For those of you who have very, very good grades in science and math, that means to say that you have a predominant left brain that is well developed. You're good in numbers. The right brain, actually, the right hemisphere controls movement on the left side of the body. And this is more of the imaginative area of the brain. It is going to have more holistic thought, like you are going to have a bigger picture compared to left brain people that are dominant. They usually have very detailed information of an event. So if somebody is telling you a story and the story is so detailed up to the color of what the people were wearing and so on, that means to say that they probably are going to be left brain. But if for me, I'm a right brain and I say, I went to this concert and there were so many people. That's all I can tell you. I can't tell you details exactly of what has happened in there. But anyway, the important thing here is, and I'm going to underscore over here, injuries on the left side of the brain can cause difficulty in understanding spoken and written language. So this is important, that speech is going to be a skill that they're going to lose. And injuries to the right side of the brain is going to be something that is going to be a loss of the big picture thinking and decreased awareness of deficits. So I'm going to go to the next slide because it summarizes what I want to emphasize as far as the hemispheres of the brain. So if you have a right hemispheric stroke, so we would call damage to the right hemisphere a right hemispheric stroke, you will have left side weakness. And you will have also visual inability to see the left field and poor decision making. And this is going to be something that is going to be very important. The patient will have behavioral problems. They will have impulsivity and inappropriateness. Now, left side hemisphere damage to this area would cause a right-sided hemiplegia as well as aphasia, agraphia, and apraxia, and visual inability to see the left-right field and memory problems. So I'm going to have a blank screen, and I'm going to ask you to see if you could identify which hemisphere is damaged. A patient is able to talk. Is it right or left hemispheric stroke? The patient has the ability to talk. They're talking.
Right.
Right hemispheric stroke. Okay. And a patient does not turn at all. Okay. So that would be left, and I will explain that later on. How about who has a greater propensity to fall? Right hemispheric stroke or left hemispheric stroke?
Left.
It would be the right. Okay. So I always write it this way. Whenever I'm trying to remember, hyperactive would be right hemispheric stroke. Slow would be left hemispheric stroke. So what do I mean by hyperactive? Well, they're talkative, okay? And they're always turning. And they're going to have a higher incidence of falls. Slow, they cannot speak. They hardly move. And they could be depressed because it's slow. All right. So patients who are going to have a right hemispheric stroke are also going to have left hemiplegia. They will also have left hemianopsia. And likewise over here, a left hemispheric stroke will have a right hemiplegia. And they will have right hemianopsia, or disturbances on their visual field. Okay, so let me do this again. All right. So in right brain damage, there's paralysis on the left side. There's going to be left side neglect. There's going to be spatial perceptual deficits. They tend to deny or minimize problems. They have a short attention span. They're impulsive. They have impaired judgment and impaired time concepts. And that's why this patient, the right brain, right hemispheric damage, is going to be more at risk for falls. The one on the left brain, the left hemispheric damage, is going to have paralysis on the right side, impaired speech, language, and they're going to be slow performance, cautious, and impaired comprehension related to language. So the other L. Okay. So what are the other nursing implications over here? The major or the frequent questions in Nclex is, where would you position the call bell on a patient with right hemispheric stroke? What do you think?
Left side.
Huh?
Left side.
The left side?
No, you remember right hemispheric stroke, which one will be paralyzed?
Oh, the left will be paralyzed.
Yeah, so you need to put it on the same
Oh.
side. Okay. The other
Yep.
things were Nclex, in my collection of questions that Nclex have asked, would be, where would you put the bedpan on a patient that has had a left hemispheric stroke? Where would you put the...
On the left side.
Yes, on the
Yes.
same side, because that's their good side. Okay? So always remember that.
Oh, okay.
Who is talkative? Right or left? Who can talk? Which stroke?
Right?
Right. Okay, very good. So always remember hyperactive, what I told you, hyperactive. You cannot be hyperactive if you cannot talk. And the slow is going to have the left language problems, which includes your aphasia. And of course, you're going to have also the inability to read, because that's the same thing. It's languaging. Okay? All right. Now, another common thing that comes out in Nclex is where the speech centers are located. All right. So what is the Broca's area? For you to be able to move your muscles that are going to produce the language, this is what's called Broca's area. And so when you have Broca's aphasia, you will have expressive aphasia. You know what you want to say, but you cannot move and coordinate the muscles of speech, and therefore you're not going to be able to talk. Wernicke's area is something that's going to be also called fluent aphasia. And the reason why it's fluent aphasia or receptive aphasia is this is going to be the person does not have any issues with speaking, but the words they say do not make any sense. So this is why it's called fluent aphasia, the Wernicke's area. Okay, so Broca's area is going to be producing the language, and Wernicke's area is understanding the language. All right, so that's the difference between the two. Now, you could also have a damage on both areas, and when you have both areas that is damaged, we now have called global aphasia. Okay, let's go to another question over here. All right. So in patients with right-sided brain damage, you are going to have left weakness, isn't it? Left side hemiplegia. So this is going to be incorrect. You remember that they are not able to language, L for language, and therefore this is going to be more for left-sided brain injury. And so the correct answers here are letter B, D, and E. Impulsive and short attention span, and there's going to be a left neglect, meaning to say they forget that they have a left side. Okay, let's go to the next one. All right, you're not doing bad. That's very good. So we have, it said, what signs and symptoms are noted with left hemispheric stroke? Okay, so letter A is going to be correct. They will have aphasia and agraphia, right? And the impulsive one is going to be right hemispheric stroke. So this is not going to be correct. Impaired math skills, you remember I told you that I'm not a left-sided individual. And so these individuals are very good in math. And of course, there's going to be issues with seeing on the right side, like right hemianopsia. And there's going to be depression because slow is depressed, and anger. And so it's A, C, D, and E. Okay, so
I have a
that,
question.
sure, go ahead.
For left hemispheric stroke, that means
Mhm.
they have damage on the right side or on the left side?
No, left hemisphere means to say that the left brain is the one that's damaged. So you remember this, the manifestation will be on the right. Oh, why is it not moving? I wanted to show you this. Okay, so whenever we have a stroke over here, right here, okay, that means to say that they're going to have weakness on the contralateral side. Even here, if you have going to have a stroke over here, it will be the contralateral side. So the confusion always is that people say when a patient has left hemiplegia, people will say she had a left stroke, and it's incorrect. What they mean is that they had a right hemispheric stroke. You understand? All right.
But can it happen on both sides or no?
Yeah, you can, particularly in hemorrhagic stroke. So in that particular instance, there's not going to be a pure distinction as far as the manifestations are concerned.
Okay.
Yeah, that's a very good point. But this is a favorite of Nclex. So I want you to be familiar with this as far as the right and the left, okay? Hemispheric stroke. So this slide is the most important one. So let me just erase the writing so that you can take a picture of it.
I'm just getting confused with like the wording of it.
Mm-hmm.
The one question was like right-sided stroke, and then the next question was like Hemispheric
Yeah.
stroke.
When you're saying right-sided stroke, that means to say the brain. Okay. It's not the weakness that occurs.
Okay.
Because our extremities are not stroked. It's the brain that's stroked. So when you say the patient had a right stroke, it is the right brain that's stroked.
And then the left side is affected.
Yes, correct. Contralateral. It's always the opposite.
And then when it says that the patient had left hemisphere, what was the last question?
Hemispheric stroke. The hemisphere. It's the
Oh.
same thing as the left brain.
So then the right side is. So it's the same thing.
Yes.
It's different
correct.
words. Okay.
I have a question.
Yeah, go ahead.
So the last question was left-sided stroke. So why was anger a part of left-sided if it's it's part of emotions?
Yeah. So look at the emotions over here. Both depression are actually what do you call that? Present in both right and left-sided stroke. But the one that is over here, cautiousness. If you're cautious, are you slow or are you hyperactive? And that is, the answer is you are slow. So my clue to the left-sided right over here, language, slow, and cautious, and depression are all going to be part of it. Now, over here, though, in patients who have right-sided stroke, remember that they are going to have impulsivity. And so most likely, this is going to have lack of concern and inappropriateness. Both of them causes depression. All right. Did I answer your question?
Yes. It's just that. Okay, so depression and anger. So anger, that's not right-sided.
No. You have to remember that anger actually is depression is actually anger turned inward. So when you're talking about depression and anger, that means to say they're one and the same thing. Okay. So again, over here, this is also going to be a very important slide. Okay, so let's go now to we did answer that. Okay, right here. All right, so whenever a patient is going to have a stroke, we always call a stroke alert in the hospital. And there are several things that we must do. And so there are time-sensitive interventions that must be done. And what are those that are imperative? And the first one is the first 10 minutes. The first 10 minutes of an entry of a patient to the emergency room, they have to be seen by the emergency room physician, and within 15 minutes, the stroke team has to have seen them. And in 25 minutes, the patient should have had a CT scan of the brain, a non-CT scan of the brain. And in 45 minutes, the results has to be available to the stroke team, and therefore they're going to make a decision, because within 1 hour, we have to have the initiation of fibrinolytic therapy. And what is fibrinolytic therapy? This is the administration of an enzyme such as alteplase, for example, in order to dissolve the blood clot in the brain. So fibrinolytic therapy obviously is only going to be done in patients with ischemic stroke, not with hemorrhagic stroke, for obvious reasons. It is important that this particular therapy, the fibrinolytic therapy, is given within 3 hours of the last time the patient has been found to be normal. So those are the general principles. So within 60 minutes, there has got to be a needle. That means to say that treatment for this patient with a fibrinolytic agent in order to save the brain tissue. Okay? So these are the reasons why these are time-sensitive interventions. So going back now to assessment of the patient, what are the clinical manifestations? Well, the manifestations include motor loss like hemiplegia or hemiparesis or flaccid paralysis, communication loss such as dysarthria, which is going to be difficulty in speaking, difficulty in forming words, as well as apraxia. And apraxia, of course, is inability to perform a previously learned task. And lastly, we will have perceptual disturbances and sensory loss, which means to say that you can have homonymous hemianopia. And hemianopia is merely going to be a loss of vision in one field. So, for example, right over here and right over here. So both right is going to be affected, or both left is going to be affected. Okay, so that is homonymous hemianopsia, as well as visual and spatial relationships. They see an object, they try to reach it, but they're doing like this because they have spatial problems, visual spatial problems, and of course, impaired cognitive and psychological effects. When you graduate, I don't know if you have done this, but I know that I used to coordinate the critical care program for hospitals, and so the nurse interns from Broward General as well as Memorial and also Cleveland Clinic would come to our course. And one of the requirements is that they all have to finish the NIH scale, all right? And so the NIH scale is going to evaluate the patient's neurological state. So this is the NIHSS. Have you ever done this, or this is something that you would do when you graduate?
No, they taught us, well, they showed us how to like read it in ortho.
Yeah, it's a 3-hour video based program. It's difficult. It really is difficult. I had to do it twice to understand it, really. And so that's why it probably is not taught in the nursing school. But anyway, just to know, the NIHSS, or the stroke scale, is going to evaluate a patient, and they're going to score the patient from 0 to 42. And this is the important thing that you have to remember. 0 means to say that there's no stroke, obviously, right? There's no stroke. But when we have a score between 21 to 42, that means to say that there are going to be severe symptoms of stroke. So this one indicates that the patient has stroke from 21 to 42. Now, there are 11 areas that are scored. So as you could see, the first one is level of consciousness, and then gaze, visual fields, facial movement, motor function, limb ataxia, sensory, language, articulation, extinction, or inattention. All these areas are going to be, assessed in this particular survey. All right. Okay, so let's go to another poll. Slide 31. Okay, the important thing, word, I think, in this question is that the patient has an hemorrhagic stroke, the intracerebral hemorrhage. And now the patient tells you that they take warfarin or Coumadin. So that means to say that this probably will have to be reversed because of the fact that the patient is now bleeding. All right. So what are the antidotes? So again, warfarin, the warfarin. The antidote for Coumadin is vitamin K. And the other antidotes you have to remember, particularly TPA. This is something that we would give for patients who are having a stroke. This is known as a fibrinolytic agent. And the antidote for this is aminocaproic acid. And then, of course, for heparin, you all know that your antidote is going to be protamine. So these antidotes are important to remember. Okay, warfarin for vitamin K with vitamin K, TPA with aminocaproic acid, and heparin with protamine. Okay. All right, so you remember the maximum score is 42. So anywhere from 21 to 42 is actually a severe stroke. So the correct answer here is going to be letter B. Okay, we now go to the diagnoses that are going to be relevant in a patient with stroke. We always do a capillary glucose check. Why is that? The reason is the symptoms of hypoglycemia, like in a hypoglycemic shock, mimic actually the signs and symptoms of stroke. Therefore, it's imperative that one of the first things that you need to do whenever a patient presents with signs and symptoms of stroke is to obtain a capillary blood glucose. Because again, as I said, they share the same signs and symptoms. CT scan, PET scan, MRI, angiography, and lumbar puncture are also other things that we can do in order to assess for the presence of a stroke, as well as EEG, skull X-ray, ECG, and echocardiography for obvious reasons. And what is the medical management? Well, for patients who are going to have a stroke, one of the things that we are going to have to do is to reopen that artery that has been blocked. But we can only do this in ischemic stroke. We cannot do it for hemorrhagic stroke. So the treatment for ischemic stroke is the administration of a fibrinolytic agent. A fibrinolytic agent dissolves existing blood clot. And so the most common one that we use is recombinant tissue plasminogen activator, also known as TPA. And actually, it is better known by that name, TPA. And TPA obviously is going to mean tissue plasminogen activator. So again, this treatment is only for ischemic strokes and must be given within 3 hours in order to be effective. And the criteria is that the CT of the head should be negative for hemorrhage for obvious reasons. And then the blood pressure has to be controlled, meaning to say that the systolic blood pressure could not be more than 185, and a diastolic blood pressure could not be more than 110. And of course, the glucose should be controlled, and that the patient should not be receiving anticoagulants. Okay. The other way in which we could treat stroke is to mechanically go to that artery and remove the obstruction that is occurring. And that is what's known as mechanical thrombectomy. So these are the important ones that I listed right over here as far as the management of ischemic stroke is concerned. So what are some of the nursing implications for the administration of activase or TPA? Well, before treatment, make sure that the last symptom was less than 3 hours, because if the symptom has been more than 3 hours, then that means to say that the patient is no longer going to be eligible for this particular treatment. And then, of course, confirm eligibility, and the eligibility is going to depend on the facilities, but usually these are the exclusions. So who do we not give this treatment to? If the patient has had a head trauma in the last 3 months, a stroke in the last 3 months, a subarachnoid hemorrhage in the past, a previous intracranial hemorrhage, active bleeding, heparin in the last 2 days, an elevated INR, hypoglycemia, a very big or large brain infarct, and platelets that are going to be low, meaning less than 100,000 per cubic millimeter. So it actually is very easy to remember the absolute exclusions, because what we're doing is we're going to give a drug that dissolves an existing blood clot. So wouldn't it make sense that if we're doing a drug that is going to dissolve a blood clot, you don't want any bleeding history? So that's number one. Like stroke, previous intracranial hemorrhage, active bleeding, use of heparin, an elevated INR, and platelets that are low, all those are going to be very easy to remember. Okay, so those are the exclusions. And then, of course, make sure that you have labs. The labs would include your CBC as well as your PT-INR, glucose, and pregnancy test. All right. So this is important because we're going to endanger the fetus if we're going to give fibrinolytic agents. Therefore, pregnant individuals cannot be candidates for this one. And then, of course, keep the systolic blood pressure less than 185 or diastolic less than 110. We usually give them 2 to 3 IV lines. And this is so that we have enough access, because after we start fibrinolytic therapy, we can no longer do invasive procedures. In other words, we cannot insert a catheter, we cannot insert an IV, we cannot give intramuscular injections because of the danger of bleeding. And then, of course, because the dose of the drug is going to be based on weight, we're going to actually weigh the patient and make sure that we do ECG monitoring. All right. So during therapy, what are some of the interventions? Well, make sure that we are going to perform your assessment continuously. And when I say continuously, every 15 minutes during the first hour of infusion. And we always have to assess for bleeding, as well as monitor for signs of increased intracranial hemorrhage or intracranial pressures. Monitor signs of increased intracranial pressures. And also for allergic reaction And one of the most telling of allergic reactions would be swelling of the tongue. So this is what's called orolingual angioedema. And we're going to discontinue the infusion if the patient develops a severe headache, if there's acute hypertension, or worsening of the neurological exam. So usually these are interventions that emergency room nurses are used to. And after therapy, what are some of the things that we still need to do? We still need to continue monitoring the neurological signs up to 8 hours from post-infusion. Oops. Up to 24 hours after discontinuation of the drug, right? And obviously, we need to continue monitoring for bleeding. No invasive catheters after this procedure for at least 24 hours, right? And follow-up scan, CT scan is usually done 24 hours after the procedure. Okay, so let's go to another poll. Very good. The answer is letter C, 3 hours after the onset of symptoms. Remember that TPA dissolves the clot, blocking the blood vessel, and it should be given within 3 hours after the onset of stroke symptoms. Okay, so the correct responses are letter B and letter D. Patients who are experiencing signs and symptoms of a hemorrhagic stroke or who have a blood pressure above 185 or has received anticoagulants like heparin or Coumadin, for example, are not candidates for TPA. All right. And of course, TPA is only given for ischemic stroke.
Is this a select all that apply, or is it a select or a one answer question?
Oh, it's select all that apply, but I only had one single choice. I'm sorry. Okay. So I apologize. Thank you for telling me. So the correct answers here are A, C, and D. And so let's see A, C, and D. All right. So I think it's self-explanatory for letter C and letter D, isn't it? Now, in the plan of care, actually, we always want the patient to be on antiplatelet agents like warfarin therapy in order to prevent, again, reocclusion or occlusion of the blood vessels in the brain that are likely narrowed already anyway. Okay? Now, aspirin twice a day has been found out to be of no use. And the reason for that is that actually, when you use aspirin twice a day, it predisposes you to other complications. And what are those other complications? Well, GI bleeding for one. And if you have had hypertension, we usually don't want to give aspirin because of the possibility that the patient might have an aneurysm, and therefore it might cause the bleeding to occur. And that's why we rather give antiplatelet agents rather than aspirin. Okay? Twice a day is too much. All right, so the medical management of patients with stroke includes your furosemide, mannitol, and usually these are diuretics to decrease cerebral edema. Phosphophenetoin, which is going to be something that prevents seizures from happening. It usually is actually an anti-epileptic agent. And then benzodiazepines are used to reduce skeletal muscle spasms. And those are going to be the drugs that are going to be used. Now, the additional medical management, you remember I said aspirin, if used, has to be given in small doses, 160 to 325, not going to be BID. And atorvastatin, high-dose statin usually is given because if there is a thrombus that's growing and growing, we want to make sure that we are going to prevent further occlusions from happening. For hemorrhagic stroke, the unfortunate thing is that the only thing that we are going to be able to do is to do surgery. And that includes patching the aneurysm or clipping the aneurysm itself. And we could also do that for patients who have blood clots lodged in the carotid arteries, and that is what's called an endovascular thrombectomy. So that is usually the surgical interventions that are going to occur. So as far as nursing management is concerned, during the acute phase, usually these patients will be on a ventilator, and we also are going to control their blood pressure, but we only treat them when it's over 220 over 120. This is after TPA. But before TPA and during TPA, this is going to be less, okay? Now, why is it that we would allow the patient to have a blood pressure of over 200? Because you remember, we only treat them if it's 220. If this is the brain, if this is brain tissue, and this is the blood vessel. Now, when you have injury to the brain will swell. So this is going to happen. The brain is now going to close up your vascular bed. So would you require higher pressures to maintain circulation here or lower pressures? And the answer to that is higher pressures. Because if you allow the blood pressure to be 120, it might not be strong enough to push blood into these constricted vessels. All right? And so that's why we only treat them if it's over 220 over 120. And then, of course, we always need to assess for the neurological state and prevent complications. You have been taught how to prevent contractures, for example, as well as preventing venous stasis and other deformities, including pressure ulcers. All right, so this means to say that the nursing assistant is doing something wrong. Okay, so letter A, let's examine that. Providing passive range of motion to the left extremities during the bed bath. Well, is this good or bad? I mean, it's not necessarily bad if you're going to do passive range of motion, right? This has to be done on both extremities anyway, so this is okay. Elevating the foot of the bed to reduce edema. This is also okay. And of course, the reason is good. Pulling up the client under the left shoulder when getting out of bed to a chair. All right, so let's question mark this. Putting high top tennis shoes on the client after bathing. This is good intervention because it prevents foot drop. So for those of you who've been to neurological floors, a neuro, patients are in bed, but they're actually wearing shoes. And the reason that they're wearing shoes is those shoes are to prevent foot drop. So that's a good intervention. But pulling up the client under the left shoulder, this has a potential for causing injury to the brachial plexus. And that is the reason why we always have to, whenever we lift patients who have had a stroke, we should not pull them from the axilla. We should always use a lifting sheet or a draw sheet. Okay, so this is problematic. Letter C is incorrect, is not a good intervention, and therefore we need to teach the nursing assistant to avoid doing that.
I have a question.
Yeah, go ahead.
In this case, will the left-sided paralysis means the brain is affected or just paralysis in general?
So the left-sided paralysis, so the brain that's affected is the right hemisphere. So the
Okay,
patient has had a right hemispheric stroke.
because
Okay.
how I'm thinking, I wasn't really thinking. Okay, I think I understand. Because
Yeah.
I just wanted to know they use the word paralysis, so it's like a different way to say, okay, whatever hemisphere is affected. So it's
Yeah.
still talking about the brain.
Yeah. So
Oh,
Nclex is going to confuse you. Okay. And
yeah,
that
that's
is
what I'm
why
like, huh?
and that is why I wanted to emphasize this. When they say right hemiparesis, for example, that means to say that the brain that was infarcted brain is going to be the left side. All right. When they say the patient has left hemianopsia, meaning to say that there's going to be loss of vision on the left, that means to say that they had a right brain hemispheric stroke. And again, this is going to be very critical because do not confuse when they say paralysis, that means to say that the opposite is going to be the damage. So if they say left-sided paralysis, what part of the brain is damaged?
Right.
Right.
Right. Okay. If they say the patient has a right hemiplegia, then the damage is on the left. Okay.
Okay.
So
So
don't
they're
be
just tricking
confused with
us.
the don't be confused with the hemiplegia and the hemisphere. Okay. All right.
Okay.
So this is another question that I'm glad that this question come out. No, this is different. Yeah. Sorry. Very good. So if the patient is blind on this side, obviously you have to teach them to make sure that they turn their whole face to the other side frequently in order to compensate for the loss of vision. So hemianopsia, again, make sure to teach the patient to scan the room. All right. So what are some of the other nursing interventions? Well, feeding is going to be a problem because dysphagia is going to be a complication associated with these strokes. So whenever we're feeding them, we need to observe them for paroxysms of coughing, but we never should feed them until such time that a speech pathologist has done a swallowing test. So we usually keep them NPO until after the speech pathologist has done a swallowing test. And there are interventions, obviously, in order to decrease aspiration. And so one thing that is going to be important is that we need to thicken fluids. So contrary to belief, liquids are harder to swallow in patients who are compromised. The reason is when you drink liquids, there are more muscles that need to control their movement down to the GI tract in order not to go into the trachea or the respiratory tract. So whenever we give liquids, we have to thicken them. And this is in order to facilitate the safe swallowing of the food bolus. Now, coughing or choking while eating or drinking are symptoms of dysphagia. And also, food left in the mouth or throat after swallowing is going to be symptoms of dysphagia. So always make sure that you address these things. Very good. So the correct answers are letter C and letter D. You ask questions that require a simple response as well as using a communication board. Now, the temptation of most caregivers, including nurses, is that they want to complete the sentence for the patient. Do not do that, okay? Letters C and D are the two most profound nursing interventions that you can do. Let the patient speak, be direct, and ask simple questions that require a simple response, and of course, use the communication board. All right, we could also improve communication by being consistent in schedule, as well as developing checklists, as well as giving the patient simple instructions. All right. So this is going to be aphasia, and remember that Wernicke's aphasia is going to be a fluent aphasia. A non-fluent aphasia is going to be Broca's aphasia. And then there's also global aphasia, wherein both Wernicke's and Broca's areas are going to be involved. So let me just take a few minutes to talk about what are the important interventions for patients with aphasia, the different kinds of aphasia. So in receptive aphasia, remember that they're unable to understand what you're talking about. So I see nurses pleading with these patients, or sometimes scolding them, but these patients do not understand speech. They do not understand speech. So when you communicate with them, short phrases is important, and gesturing. Okay, so gesturing is the most important thing, because remember, they do not understand the language. And make sure that the patient, you are patient, because the patient will take a long time in order to respond to your communication. For expressive aphasia, that's Broca's aphasia, this is going to be a situation wherein the patient comprehends speech, but they could not answer back. So they understand you. So therefore, you need to be patient and let them speak. And of course, be direct when asking questions. For example, giving them options. Would you like some apple juice, orange juice, or Coca-Cola? Instead of saying, do you want something to drink? So you're giving them options. And then, of course, a dry eraser board is going to be very important. And there's another problem is going to be sensory perceptual deficits. That means to say that the patient's perceptual ability is going to be compromised. So always approach the patient, for example, with a decreased field of vision on the side where the perception is going to be intact. And always put all the visual stimuli on the side that they can see. And I said we need to teach the patient to look around and turn in the direction of the defective visual field. And make sure that there's good lighting, and remind patient with hemianopsia of the other side of the body, because they usually are going to forget that that part of their body exists. And this is another challenge, is again your hemianopia or hemianopsia. And there are several combinations of visual field deficits. So the most common ones, though, are your homonymous hemianopia, which means to say that they're going to be on the same side. So the blind area is going to be in here. This is the right side, right? This is the right side. But there could also be heteronymous hemianopia, such as this. They're not on the same side, but this is a little bit advanced. So whenever you have hemianopia or hemianopsia, the things that you're going to have to do is to make sure that you approach the patient from the side of good vision and teach them again to scan the environment. Okay, so this is a little bit tricky. It says, what are priorities in planning the care? So, which means to say that this is the immediate part of the recovery phase. So obviously this is going to be correct, this is going to be correct, and these are going to be correct. So this one, stroke prevention, probably right before discharge would be, it's not a priority. And reorientation exercises, usually patients who have stroke are not going to be disoriented. But when they are, obviously we're going to reorient them on the latter part of the disease process. So the priorities would be this A, B, and C. Okay, so what is apraxia? Apraxia is the inability to perform a previously learned function. So we all know that when we itch, we obviously know that we need to scratch, right? Or when we have a, what do you call that? Foreign body in our eyes, we need to wink or even to blink, I should say. So this letter B actually describes what apraxia is. The other thing that we usually do to patients is we would give them a pen, for example, and we're going to ask them, what would you do with this? And so when they start brushing their teeth with it, then that means to say that they have apraxia. Okay, so those are the nursing interventions for these patients, is that you need to reteach them previously learned functions.
Good question.
Yeah.
So reading be considered a skill then in this sense? Just
Which-
random asking.
Which one?
The patient is unable to read. Would that be like a
Okay.
skill instead of a
Yeah,
function?
but that is going to be a another term. So agraphia or alexia are all the other
Okay.
terms that would be used to describe. Agraphia is the loss of the ability to write, and alexia is the inability to read. They are blind as far as the words are concerned. So I included over here, and I wanted you to please take a shot or a photo of these terms so that you will be familiar with them.
There's a lot of vocab for this.
It is, and that is why there's a lot of things that you need to remember in stroke. And unfortunately, Nclex actually loves to give a lot of questions on stroke. So I encourage you to please take a shot of this one and do it. We did not have a break, but do you mind if we just go ahead and continue, because we're now on the case study?
Yeah,
So
it's okay.
Okay, all right, good. I don't know if somebody is dying to have a break or something. All right, so this is the case. We have a 26-year-old female, all right, of Latin descent, presents to the ER with lightheadedness, generalized weakness of the left lower and upper extremities. All right, so the patient has left and lower upper extremities weakness. So what side of the brain are we talking about?
Right.
Good. All right.
Go, Lindsay.
And a sudden headache after completing a 2.5-mile sprint. Reports some nausea but no vomiting. Thinking she was dehydrated from her exercise, she drank about a liter of water and self-administered 500 milligrams of acetaminophen for pain with no improvement. She reports the symptoms began approximately at 9 o'clock, no significant previous medical or surgical history. takes an oral combined hormonal contraceptive. I forgot that this is also a risk factor, by the way. Contraceptives. Occasionally drinks 3 to 4 glasses of wine a week and vapes with e-cigarettes daily. Wow. Continuous cardiac monitoring initiated per protocol, heart rate 99, blood pressure 160. She is awake and alert and can make her needs known. Voiding clear yellow urine, abdomen is soft with bowel sounds in all quadrants, reports increasing numbness to the left side and lower extremities. All right. So the first question is, which of these findings require immediate follow-up? Okay, let's take a look at this. Now, would you be concerned because the patient is lightheaded? And I certainly would. So this would, these are all signs of neurological insult. And so I would certainly choose lightheadedness. And then weakness of left upper extremities. Whenever you have one-sided weakness, this is always going to be a clue that something is happening in the brain. And sudden headache, I obviously will want to have this. Now, self-administered 500 milligrams of acetaminophen, that doesn't have any bearing, isn't it? And this one either. I mean, it will not cause a stroke. And this one either. It's 99 per minute. But this one probably would be significant. Do you all agree? All right. So somebody said letter E, answered letter E. You remember drinks 3 to 4 glasses of wine a week is a risk factor, right? But it does not require immediate follow-up. You see what I mean? You're going to follow this up on discharge, right? This woman, you remember that women are supposed to be okay with just 1 drink per week. So this is okay. You are going to deal with it later on. Okay, so let's go to the next one. For each finding, click to determine whether or not it is a risk factor or not a risk factor for the ischemic stroke. Okay, so let's go ahead over here. I think that combined hormonal contraceptive is going to be a risk factor because of estrogen being present. So this is a risk factor. And drinks 3 to 4 glasses on alcohol a week. Vapes, yes. Completed a 2-mile. This is not a risk factor, and this one is a risk factor. Okay, great. So let's go to the next question. So at 11:30, a 20-gauge IV was placed in the right and left antecubital per protocol. Blood work was drawn and results returned. Head CT shows ischemic stroke. Lab glucose 186. This is elevated. Hematocrit 55. That is going to be elevated as well. Hemoglobin 13. That's okay. And platelets 500,000 per cubic meter. It's a little bit elevated. And PT is 13.5 seconds. All right. So she was ordered to have alteplase, 0.9 milligrams per kilogram over 60 minutes IV stat, bolus of 10% dose, and labetalol, 20 milligrams IV, then 10 milligrams IV to maintain systolic blood pressure above 140 but less than 185, and a diastolic above 80 but less than 110. Okay, so can you remember that? Because we're going to go now to this one. So the nurse reviews the healthcare's provider order and plans to administer alteplase. What additional assessment data should the nurse obtain before administering alteplase? So select all that apply.
This is a different question.
No, this is a different question. I'm sorry. And the Paul. Let me see. Here. I love it. I think you all are getting it. Okay. So it is contraindicated in pregnancy, right? And so letter A is going to be correct. No current pregnancy. So this is correct. And you remember that the blood glucose should be well controlled. So this is going to be okay. No major surgical procedures. That's okay. This one doesn't have any bearing at all. Correct? And also this one doesn't have any bearing. But this one, we have to give it within 3 hours. So obviously, this is going to be important. The potassium and this ability to ambulate is not going to be okay. But client weight is going to be important because we're going to calculate the dose of the alteplase based on weight. Okay. And let's go to the next one. Number 5. All right, so actions after giving alteplase. Okay, let's see. Ensure oral anticoagulants are withheld for the next 24 hours. Obviously, we need to do this, right? So this is indicated. Arrange for an inpatient admission to the medical surgical unit. Well, whenever we have a patient that has had alteplase, we have to put them in ICU. So this is not indicated. Assess and monitor vital signs for intracerebral hemorrhage. This would be indicated. Insert an indwelling catheter. You remember, no invasive procedures. All right. So nobody, you all got that correctly. Consult with hematologists to increase the client's PT and INR levels. While this is not going to be an indicated, the reason is that we just give them fibrinolytic, and therefore their PT and INR is already going to be elevated. And then keep the client NPO. Obviously, we should never give anything by mouth to a patient until after the speech therapies has done the swallowing evaluation. And monitor for serum levels to prevent complications of a stroke. Yes, that would be appropriate. Okay, I think you did good in that question. All right, so the last question is, click to specify whether the statement indicates an understanding or no understanding of teaching that is provided to this patient. So let's see. Okay, so let's see. I will use the call bell and wait for someone to help me get out of bed. This is obviously correct. It is a manifestation of the understanding that he has, because these patients are going to be at risk for falls. A speech and swallow test will determine if I can drink normal again. Yes, this is an understanding, because before we give anything to the patient, the speech pathologists would have to do a swallow test. I will switch to an electric razor. This is also going to be understanding because of the fibrinolytic therapy that that was given. the physical therapist will determine my functional ability. I don't know about this one. For functional ability, actually, the patient has to be assessed by the nurse as far as to what extent can he do or can she do things for himself. So I don't know about this. At discharge, I should plan to self-administer for hyperglycemia. Well, there's no need for that. Just because that the patient had the stroke doesn't mean to say that they're going to require insulin. And I will follow up my gynecologist to determine a better contraceptive plan. Yes, because we want a contraceptive that does not have estrogen, because estrogen actually causes the fibrinogen in the plasma, specifically factors 7 and 10. It increases the stroke, and so this is going to be correct. All right. So that ends my presentation on stroke. It certainly has been a long one, but I hope that you gathered enough information so that you can have enough armament to deal with Nclex. Okay?
Thank you.
Yeah,
Thank
so
you.
I hope to see you again tomorrow. I mean, no, next week.
Next week.
Yeah, see you on
Tuesday.
Tuesday. Yeah.
Okay.
All right. Have a great
Thank-
weekend.
You
You
too.
too.
Thank you.
Great.
Thank you.
Bye-bye.